CNS vasculitis, a review. CNS vasculitis, or central nervous system vasculitis, refers to the inflammation of the blood vessel walls in the brain and spinal cord. It is a rare but serious condition that can lead to a range of neurological symptoms due to the reduced blood flow and subsequent damage to brain tissue. CNS vasculitis may occur as a primary condition, primary angiitis of the CNS, PNS, or secondary to other systemic diseases. Classification 1. Primary CNS vasculitis occurs in isolation, affecting only the CNS without systemic involvement. 2. Secondary CNS vasculitis, associated with systemic vasculitides such as systemic lupus erythematosus, SLE, granulomatosis with polyangiitis, GPA, polyarteritis nodosa, Behçet's disease. Pathophysiology. The primary pathological feature of CNS vasculitis is inflammation of the small to medium-sized arteries and veins. This inflammation leads to vascular occlusion, ischemia, and infarction, which manifest as a variety of neurological signs and symptoms. The exact cause of PACNS is unknown, but secondary CNS vasculitis often results from an autoimmune process, infection, or drug reaction. Clinical presentation. Symptoms of CNS vasculitis are often nonspecific, making diagnosis difficult. Common presentations include headache, most common symptom, stroke or transient ischemic attacks, TIAs, cognitive dysfunction, seizures, altered mental status or encephalopathy, focal neurological deficits, behavioral or psychiatric changes. Diagnosis. The diagnosis of CNS vasculitis is challenging due to its rarity and nonspecific presentation. It requires a combination of clinical suspicion, imaging, and in many cases, biopsy. Common diagnostic approaches include 1. Imaging, MRI, the preferred imaging modality. It may show areas of ischemia, infarction, or hemorrhage, often in multiple vascular territories. MRA-CTA can help detect stenosis or occlusion in larger vessels. Conventional angiography, the gold standard for visualizing vessel abnormalities like narrowing, beading, or occlusion, but may miss changes in small vessels. 2. Lumbar puncture may show elevated protein levels, pleocytosis, increased white cells, or oligoclonal bands, although findings are nonspecific. 3. Brain biopsy remains the definitive diagnostic test. It can show evidence of vasculitis, such as inflammation of the vessel walls. However, it is invasive and often avoided unless absolutely necessary. 4. Laboratory tests. Tests like ESR, CRP, and autoimmune panels can help in identifying systemic causes but are not specific for CNS vasculitis. Infectious workup may be indicated to rule out other causes. Differential diagnosis. CNS vasculitis must be differentiated from other conditions that can mimic its presentation, such as stroke, multiple sclerosis, infections, e.g. meningitis, encephalitis, neoplasms, drug-induced vasculitis, other autoimmune diseases, e.g. SLE, antiphospholipid syndrome. Treatment. The treatment of CNS vasculitis depends on whether it is primary or secondary. In general, immunosuppressive therapy is the cornerstone of treatment. 1. Corticosteroids. High-dose corticosteroids, e.g. prednisone, are often used as initial therapy to control inflammation. 2. Immunosuppressive agents. In cases where corticosteroids alone are not sufficient or for long-term management, immunosuppressive drugs such as cyclophosphamide, azathioprine, or mycophenolate mofetil may be used. 3. Biologics. Rituximab, an anti-CD20 monoclonal antibody, may be effective in refractory or severe cases, especially in systemic vasculitis with CNS involvement. 4. Antithrombotic therapy. Antiplatelet or anticoagulant therapy may be indicated in cases with a high risk of thrombotic complications. Prognosis. The prognosis of CNS vasculitis varies widely and depends on early diagnosis and treatment. Untreated, the condition can lead to severe neurological damage and death. With prompt immunosuppressive therapy, many patients can achieve remission, but relapse is not uncommon. Long-term follow-up is essential to monitor for relapses and treatment-related complications. Conclusion. CNS vasculitis is a rare and potentially life-threatening condition that requires a high index of suspicion for diagnosis. Early recognition and aggressive treatment with corticosteroids and immunosuppressants are key improving outcomes. A multidisciplinary approach involving rheumatologists, neurologists, and radiologists is often necessary to manage this complex disorder effectively. Primary angiitis of the central nervous system, PNS. Primary angiitis of the central nervous system, PACNS, also known as isolated CNS vasculitis, is a rare, idiopathic inflammatory condition confined to the blood vessels of the brain and spinal cord. Unlike secondary CNS vasculitis, PACNS does not involve other organs, making diagnosis particularly challenging. Epidemiology. Incidence. Rare, with an estimated incidence of 2.4 cases per million person years. Age of onset can occur at any age but is most common in middle-aged adults with a slight male predominance. Risk factors. No well-established risk factors exist. However, some cases are thought to be triggered by infections, environmental exposures, or possibly genetic predispositions. Pathophysiology. The underlying cause of PACNS is poorly understood. It is characterized by inflammation of the small to medium-sized arteries, veins, and arterioles in the CNS, leading to vessel occlusion. Inflammation can cause narrowing or complete occlusion of affected blood vessels. Ischemia. Reduced blood flow leads to ischemia, which can cause strokes or focal neurological deficits. Infarction. Prolonged ischemia may result in infarcts in different parts of the brain or spinal cord. Unlike systemic vasculitides, PACNS does not involve systemic organs such as the kidneys, lungs, or skin. Clinical presentation. The clinical presentation of PACNS is varied and nonspecific, often making the diagnosis difficult. Common symptoms include 1. Headache. The most frequent presenting symptom, typically described as diffuse or persistent, often refractory to usual treatments. 2. Cognitive decline. Patients may present with memory loss, confusion, or other cognitive deficits. 3. Stroke-like events. Multiple ischemic events, often in different vascular territories, can mimic recurrent strokes or transient ischemic attacks, TIAs. 4. Seizures. Seizures may be focal or generalized and can be the first sign of PACNS. 5. Focal neurological deficits. Symptoms can include weakness, numbness, aphasia, or visual disturbances, depending on the vascular territory affected. 6. Behavioral or psychiatric symptoms. Changes in mood, personality, or psychosis may occur in some cases. 7. Encephalopathy. Diffuse brain dysfunction presenting as confusion, delirium, or decreased consciousness is less common but possible. Diagnosis. The diagnosis of PACNS requires a combination of clinical suspicion, imaging studies, cerebrospinal fluid analysis, and in some cases, brain biopsy. 1. Magnetic resonance imaging, MRI, the most sensitive imaging modality for detecting CNS abnormalities. Findings can include multifocal areas of ischemia or infarction, often in different vascular territories. Other abnormalities may include hemorrhages, edema, or leptomeningeal enhancement. 2. Cerebral angiography. Conventional angiography can show vessel irregularities, such as stenosis, beading, or occlusion of small to medium-sized vessels. However, it may miss smaller vessel involvement and is not entirely specific to PACNS, as similar findings can be seen in other conditions like atherosclerosis or reversible cerebral vasoconstriction syndrome, RCVS. 3. Cerebrospinal fluid, CSF analysis. Nonspecific findings such as mild pleocytosis, increased white blood cells, and elevated protein levels. No specific markers for PACNS exist, but CSF abnormalities help exclude other causes like infections or malignancies. 4. Brain biopsy. Considered the gold standard for diagnosing PACNS, though it is not always feasible. A biopsy may reveal transmural inflammation of the vessel wall, with infiltration of mononuclear cells, giant cells, and fibrinoid necrosis. Biopsies are not without risk, and a negative result does not completely rule out the disease due to the patchy nature of CNS vasculitis. 5. Laboratory tests. There are no specific laboratory tests for PACNS. ESR and CRP may be elevated but are nonspecific. Extensive workup to rule out systemic vasculitides, infections, or malignancy should be conducted. Differential diagnosis. PACNS should be differentiated from several other conditions that can mimic its presentation. 1. Reversible cerebral vasoconstriction syndrome, RCVS, characterized by a sudden onset of severe headaches with reversible vasoconstriction, which can mimic PACNS on imaging. 2. Infectious vasculitis. CNS infections like meningitis or encephalitis can cause vasculitic changes, especially in immunocompromised individuals. 3. Systemic vasculitis with CNS involvement. Systemic diseases such as lupus, granulomatosis with polyangiitis, and polyarteritis nodosa can affect the CNS, but they involve other organ systems. 4. Atherosclerosis. Chronic ischemia due to atherosclerotic disease can cause multifocal strokes. 5. Multiple sclerosis, MS. Though MS primarily involves demyelination, it can sometimes present with symptoms that overlap with PACNS, particularly when accompanied by vascular changes. Treatment. Treatment for PACNS is typically long-term and focused on controlling the inflammatory process. 1. Corticosteroids. High-dose corticosteroids, e.g. prednisone, are used as the initial treatment to rapidly control inflammation. Intravenous methylprednisolone may be used in severe or acute presentations. 2. Immunosuppressive agents. Cyclophosphamide is often added in cases that are severe or refractory to corticosteroids. For maintenance therapy, azathioprine, mycophenolate mofetil, or methotrexate may be used to reduce the long-term side effects of corticosteroids. 3. Biologic therapy. Rituximab may be considered in refractory cases or when there is concern about the toxicity of cyclophosphamide. Other biologics targeting inflammatory pathways are being explored but remain experimental for PACNS. 4. Supportive care. Anti-seizure medications are used for patients presenting with seizures. Physical and cognitive rehabilitation may be necessary for those who experience significant neurological deficits. Prognosis. The prognosis of PACNS depends largely on the timing of diagnosis and the effectiveness of treatment. Early detection and prompt initiation of immunosuppressive therapy are crucial for improving outcomes. Without treatment, untreated PACNS is progressive and often fatal due to recurrent strokes, encephalopathy, or severe neurological deterioration. With treatment, the prognosis improves significantly with aggressive immunosuppression. However, relapse is not uncommon, and long-term follow-up is essential. Some patients may develop chronic neurological deficits despite treatment. Conclusion. PACNS is a rare and challenging condition that requires a high level of clinical suspicion for diagnosis. The nonspecific nature of its symptoms, coupled with the limitations of diagnostic tests, makes it difficult to distinguish from other mimicking conditions. Timely treatment with corticosteroids and immunosuppressive agents is critical to improving patient outcomes, and a multidisciplinary approach involving neurologists, rheumatologists, and other specialists is often required. The classification of primary angiitis of the central nervous system, PACNS, is not standardized through widely accepted criteria as it is a rare and complex condition. However, based on expert consensus and various studies, a set of clinical, imaging, and pathological features can guide the diagnosis. It's important to remember that PACNS is a diagnosis of exclusion, meaning other potential causes of vasculitis or neurological symptoms must be ruled out. Proposed diagnostic and classification criteria for PACNS. 1. Clinical presentation. Onset of neurological symptoms. The presence of unexplained persistent and new neurological symptoms that develop over days to weeks. Common symptoms include chronic headache, most common, cognitive decline, confusion, memory problems, seizures, focal neurological deficits, e.g., stroke-like episodes, encephalopathy or altered mental status, behavioral changes or psychiatric symptoms. 2. Exclusion of systemic disease. Lack of evidence for systemic vasculitis, systemic autoimmune disease, infection, malignancy, or other causes of CNS inflammation. This exclusion is primarily based on negative laboratory tests for systemic diseases, e.g. negative ANA, and normal kidney function. 3. Imaging. MRI of the brain typically shows multiple areas of ischemia, infarcts, or hemorrhages in different vascular territories. Leptomeningeal enhancement may also be present. Cerebral angiography. Conventional angiography, or MRA-CTA, may show segmental narrowing, beading, or occlusions in small to medium-sized vessels. However, angiography findings alone are not sufficient for diagnosis, as they can overlap with other conditions. 4. Cerebrospinal fluid CSF analysis. Mild pleocytosis, increased white cells, and elevated protein levels are often present. Exclusion of infection through negative cultures, PCR for viruses, and other infectious agents is crucial. 5. Brain biopsy, gold standard. Histopathological confirmation of vasculitis affecting small to medium-sized vessels in the brain or meninges. Biopsy findings typically include transmural vessel inflammation, fibrinoid necrosis, or infiltration by lymphocytes, macrophages, and occasionally giant cells. A biopsy is not always required, but is definitive for PACNS diagnosis if other criteria remain inconclusive or are ambiguous. Additional features: response to immunosuppressive therapy. Improvement with high-dose corticosteroids or other immunosuppressive agents supports the diagnosis, though this is considered more of a retrospective confirmation. Diagnostic criteria summary. For a diagnosis of PACNS, the following criteria are commonly required. 1. New onset or unexplained neurological symptoms, including headaches, strokes, seizures, or cognitive decline. 2. Exclusion of systemic disease or other identifiable causes of CNS inflammation or vasculitis. 3. Abnormal MRI findings showing multiple infarcts, ischemic lesions, or hemorrhages in different vascular territories. 4. Cerebral angiographic abnormalities, such as segmental narrowing, beading, or occlusion of small to medium vessels, though not always present. 5. Abnormal cerebrospinal fluid findings, such as elevated white blood cell count or protein. 6. Brain biopsy, if performed, showing histopathological evidence of vasculitis affecting CNS vessels. Differential diagnosis, exclusion. PACNS must be distinguished from conditions like reversible cerebral vasoconstriction syndrome, RCVS, systemic vasculitis, e.g. lupus, ANCA-associated vasculitis, infectious vasculitis, e.g. bacterial, viral, fungal, atherosclerotic cerebrovascular disease, multiple sclerosis, or other demyelinating diseases. Proposed PACNS subtypes. Some researchers suggest classifying PACNS into different subtypes based on vessel size and clinical presentation. 1. Small vessel PACs, more associated with cognitive changes, headaches, seizures, and behavioral disturbances. 2. Large vessel PACs, more associated with stroke-like episodes and focal neurological deficits, detected more readily on angiography. Conclusion. While formal classification criteria for PACNS are not universally established, the diagnosis relies on a combination of clinical findings, exclusion of other causes, neuroimaging, CSF analysis, and, if possible, brain biopsy. In clinical practice, the diagnosis of PACNS is challenging and often requires collaboration among neurologists, rheumatologists, and radiologists for comprehensive evaluation and treatment. The management of primary angiitis of the central nervous system has evolved over the years with a focus on early recognition, aggressive immunosuppression, and long-term monitoring. Updated guidelines emphasize a tailored approach depending on disease severity, with corticosteroids remaining the first line of treatment, often followed by other immunosuppressive agents. Updated guidelines for management of PACNS. 1. Initial treatment. Corticosteroids. High-dose corticosteroids are the cornerstone of initial treatment for PACNS. Prednisone is typically started at 1 mg per kilogram per day, or intravenous methylprednisolone, 1 mg per day, for more severe cases over 3 to 5 days. This is followed by an oral taper, usually over several months, depending on the response. Early and aggressive corticosteroid therapy aims to rapidly control inflammation and prevent further ischemic events or neurological damage. 2. Immunosuppressive therapy. Cyclophosphamide for moderate to severe PACNS or patients with refractory disease. Cyclophosphamide is recommended in combination with corticosteroids. Cyclophosphamide can be administered either orally, 1 to 2 mg per day, or intravenously, usually as monthly pulses. The duration of cyclophosphamide use depends on the patient's response, but generally ranges from 6 to 12 months. Cyclophosphamide is particularly useful for achieving remission and preventing relapses in severe cases. Methotrexate, mycophenolate mofetil, or azathioprine. For milder forms of PACNS or in patients who cannot tolerate cyclophosphamide, other steroid-sparing agents can be used, such as methotrexate, 15 to 25 milligrams per week, mycophenolate mofetil, 500 to 1,000 milligrams twice daily, or azathioprine, 2 milligrams per kilogram per day. These agents are often used in maintenance therapy after achieving initial remission with corticosteroids and cyclophosphamide to reduce the risk of relapse. Rituximab, an anti-CD20 monoclonal antibody, is increasingly being used in cases of refractory or relapsing PACNS. It is particularly useful for patients who cannot tolerate cyclophosphamide or have contraindications. Rituximab is administered as 2 1-gram infusions spaced 2 weeks apart, or as 4 weekly infusions of 375 milligrams per milliliter. Its efficacy has been observed especially in PACNS cases that overlap with other autoimmune conditions, such as systemic lupus erythematosus or ANCA-associated vasculitis. Antiplatelet or anticoagulant therapy. There is no consensus on the use of antiplatelet or anticoagulant therapy in PACNS. However, in cases where patients experience recurrent ischemic strokes or have a prothrombotic state, low-dose aspirin or anticoagulation may be considered as adjunctive therapy. This is more applicable in cases of large vessel involvement or coexistent vasculopathies. 4. Adjunctive therapies. Antiepileptic drugs. Patients with seizures require appropriate antiepileptic drugs. Choices depend on the seizure type, but newer generation anticonvulsants like levetiracetam or lamotrigine are often preferred. Neurorehabilitation. Patients with cognitive or motor deficits benefit from early initiation of physical, occupational, and cognitive rehabilitation to maximize functional recovery. 5. Duration of therapy. After achieving remission, typically defined as the absence of new neurological symptoms, normalization of inflammatory markers, and no active disease on imaging, the patient is transitioned to maintenance therapy. Maintenance therapy typically involves lower doses of immunosuppressive agents, e.g., azathioprine, methotrexate, or mycophenolate mofetil, for 1 to 2 years to prevent relapses. Corticosteroids are tapered gradually, aiming to discontinue them completely after 6 to 12 months if possible. 6. Monitoring. Frequent clinical assessments are necessary to monitor the disease's activity and potential side effects of long-term immunosuppression. Imaging, repeat MRI, and possibly angiography are recommended periodically, especially if there is suspicion of relapse or treatment failure. Laboratory monitoring, regular CBC, liver and kidney function tests, and inflammatory markers, e.g. ESR-CRP, are monitored to assess drug toxicity and disease activity. Infection prophylaxis. Given the use of immunosuppressive therapy, prophylactic treatment against opportunistic infections may be considered, especially in those on high-dose steroids or cyclophosphamide. For example, trimethoprim sulfamethoxazole, TMP-SMX, can be used for pneumocystis jirovecii pneumonia prophylaxis. 7. Relapse management. Relapses are relatively common in PACNS. In cases of relapse, patients often require escalation of immunosuppressive therapy, such as reintroduction of high-dose corticosteroids and reinitiating or switching immunosuppressive agents. Rituximab, or switching to another steroid-sparing agent, e.g. from methotrexate to mycophenolate mofetil, may be necessary in refractory cases. 8. Prognosis. The prognosis of PACNS has improved with earlier diagnosis and more effective immunosuppressive therapy. Without treatment, PACNS can be fatal or lead to permanent neurological damage. However, with aggressive and early treatment, 80 to 90% of patients can achieve remission. Long-term follow-up is essential, as relapse rates can be as high as 25 to 30%. Prolonged immunosuppressive therapy, even during remission, may reduce the risk of relapse. Conclusion. The updated guidelines emphasize an individualized, aggressive approach to treating PACNS, involving early and high-dose corticosteroids followed by long-term immunosuppressive therapy. Rituximab is emerging as a promising agent, particularly in refractory cases. Long-term monitoring for relapse and drug toxicity is critical in managing these patients, as is ensuring a multidisciplinary approach involving neurologists, rheumatologists, and radiologists for optimal outcomes.